All right, ready?
I'm ready. All right. So we're going to take a look at the gastrointestinal system today, which is comprised of the esophagus, you got your stomach, small intestine, your large intestine, assisted by your liver, gallbladder, and pancreas. Functions of this system include digestion, mechanical and chemical, absorption of nutrients in the small intestine mainly, and then your expulsion of solid waste. So we're going to go over a few procedures: the colostomy, the gastric bypass, and the gastrectomy. Then we're going to take a look at the surgical technologist's roles, responsibilities, and their attire that they'll use during these procedures. Then we'll go over a few disease-causing organisms such as Klebsiella pneumoniae, Staphylococcus aureus, and Helicobacter pylori.
One common surgical operation performed on the gastrointestinal tract is a colostomy. A colostomy is a surgical operation in which a piece of the colon is diverted to an artificial opening called a stoma in the abdominal wall so as to bypass a damaged part of the colon. From then on, the patient's waste material is eliminated into a bag called a colostomy bag. Patients can undergo colostomies to treat colon cancer, diverticulitis, intestinal blockage, inflammatory bowel disease, and other gastrointestinal disorders. Here you can see how the cancer is obstructing the large intestine. This is a type of colon cancer, making this patient a candidate for a colostomy. The cancerous section in nearby tissue must be cut out to prevent the cancer from spreading. Here, the healthy sigmoid colon and rectum is left behind but will be inactive. Across this gap is where the remaining healthy colon is, and this is where the stoma is stitched to the abdominal wall. The stoma may look something like this, and yes, this is the patient's actual colon exposed to the outside world. From then on, the patient must adapt to using a colostomy bag, which is a bag that sticks to the abdomen right over the stoma so feces can be eliminated from the body through the stoma. Overall, colostomies provide effective treatment to patients suffering abdominal ailments, mainly of the colon.
Today, I will be discussing a gastric bypass, which is commonly known as a gastroplasty, but is categorized as bariatric surgery. This surgery is commonly used for those who are morbidly obese. And just some statistics from the CDC on obesity. Today, 5.2% of all Americans suffer from obesity. And by 2030, 90% of Americans will suffer from obesity. Obesity, you're considered obese anytime your body mass index is greater than 40. And for a gastric bypass, there are many different techniques available for this surgery. Each technique involves the small incision of a gastric pouch through the sectioning off of the stomach. Food is then drained from that pouch to the rest of the stomach. And to kind of break that down for you, a golf ball sized part of the stomach, which completely separates the two pieces in most cases. So now the much smaller part of the stomach severely restricts the amount of food that you can intake. The larger part of the stomach will never hold food again, but does aid in the part of the digestion. A Y-shaped segment of the small bowel is then attached to the new smaller portion of the stomach. The other branch of the bowel remains attached to the original stomach. This delays the mixing of food, which results in poor absorption of calories. So overall, your food now travels through your gastric pouch and no longer is in the part of the stomach. Now, there's a complication with this surgery, which is known as called dumping syndrome. And this happens when the individual does not adequately change their diet to their surgery. After you have a gastric bypass, you are only allowed 3 meals a day and no more than that. If you consume more than that, it will cause you to have dumping syndrome.
All right, we've got a gastrectomy up next, which can either be a total or partial removal of your stomach. This would usually result from you having stomach cancer to prevent its spread. So as we can see right here, we have the esophagus where your food comes down and goes into your stomach. The surgeon is holding your pancreas, your liver, and your spleen. The surgeon is going to cut the stomach out and remove it and then attach to your small intestine. So Helicobacter pylori has been causing problems for you for years and years and has resulted in stomach cancer. So incision across your abdomen, stomach is opened up, then above the duodenum, and just below the esophagus, the stomach is cut out and removed completely. The small intestine is now attached to the esophagus, and digestion can continue on that path. That will prevent the spread of cancer.
So for a surgical tech to be able to assist the surgeon during an operation, they must be wearing the appropriate personal protective equipment. The appropriate personal protective equipment that must be worn by a surgical tech during a gastrointestinal operation includes a hair cap to control the shedding of hair and microbes that live on hair particles, protective eyewear or a splash shield that prevents airborne pathogens from getting into the face or any potential splashes, a face mask to keep the surgical tech from inhaling airborne particles from the surgery as well as exhaling directly onto the surgical site, a disposable sterile gown that protects the scrubs underneath as well as the arms and torso from any messes that will arise during the surgery, gloves to protect the surgical tech's hands from microbes on soiled surgical tools, and to also protect the patient from microbes that are on the surgical tech's bare hands. And lastly, shoe covers to protect the shoes from absorbing any bodily fluids from the patient in case of any messes. Now note that all of this personal protective equipment except the goggles is disposable, allowing for a safe and easy cleanup.
A surgical tech has many responsibilities, but to just give a start, a surgical tech must maintain an aseptic technique as well as maintain the sterile field before, during, and after the surgery. Primarily before any surgical procedure, the surgical tech will set up the back table and what is known as a Mayo stand with all of the supplies needed for the current surgery. Tools and supplies do vary with each operation, but are specific to each surgery. Tools that are needed in a gastrointestinal surgery include scaffolds, retractors, cutting tools, and a stapler. Before a gastrointestinal surgery, the surgical technologist may be responsible for cleaning the surgical site where the incision will be made in the abdomen. An antimicrobial soap containing iodine will be used. This would take place pre-operatively and post-operatively. And after cleaning, the surgical technologist may drape the patient around the area of operation, either on the patient's right or left side. Handling the tools to the surgeon is the main responsibility for the surgical tech, and it's kind of what they're known to do. It is very typical for everybody to know a surgical tech for handling the surgeon tools, but there's way more than that. Another crucial responsibility for the surgical technologist is to account for any and all tools present before the surgery, and the same amount of tools must be present when the surgery is completed.
So the pathogen I chose to research was Klebsiella pneumoniae. Klebsiella pneumoniae is a bacillus-shaped gram-negative bacterium that is part of the normal flora in the colon of humans, making them facultative anaerobes as well. It is an opportunistic pathogen, meaning it takes advantage of an opportunity that's not normally available, and it can cause disease if it gains access to another part of the body outside of its common reservoir. Immunocompromised individuals are always at risk for these types of opportunistic infections, and healthy individuals are rarely affected. Some common infections and diseases that are caused by Klebsiella pneumoniae include pneumonia, bacterial septicemia, meningitis, diarrhea, cholecystitis, which is inflammation of the gallbladder, urinary tract infections, and surgical site infections. In a recent study, Klebsiella pneumoniae was found to be the most predominant organism to cause surgical site infections at 50%, followed by Staphylococcus aureus at 27.8%, and Escherichia coli and Pseudomonas aeruginosa both account for 11.1%. Common sites of infection include the respiratory tract, the urinary tract, and surgical wounds. Infections are linked to invasive devices like tools and instruments used during surgery. Klebsiella pneumoniae is not contagious, but it is communicable and can be transmitted through contact with infected surgical and medical tools or through person-to-person contact with infected wounds. So we know Klebsiella pneumoniae resides in the colon, so how could it cause a surgical site infection or even an opportunistic infection? Let's use a colostomy again as an example. So a colostomy involves creating a surgical opening in the abdomen, exposing part of the colon, which gives Klebsiella pneumoniae easy access to the surface of the surgical site. Following the operation, if Klebsiella pneumoniae is present on surgical tools that were used and the instruments were not properly sterilized, the bacteria can be transmitted to the next patient where undergoing surgery where those tools will be used. If Klebsiella pneumoniae gains access to other areas of the body or even other individuals, other medical diseases and complications can arise, especially in the respiratory tract, hence the species name pneumoniae. Virulence factors include a polysaccharide capsule that inhibits phagocytosis, as well as contributes to antibiotic resistance, the production of an enzyme known as carbapenemase that also contributes to antibiotic resistance, and cell wall receptors that enable the bacterium to attach to the host cell. Treatments for a Klebsiella pneumoniae infection include the use of cephalosporins, one of them being ceftriaxone. This antibiotic works by interfering with the bacteria's ability to form cell walls, by impairing the bonds that hold the cell walls together, which causes holes to appear in the cell walls, thus killing the bacteria. Now remember, Klebsiella pneumoniae is a gram-negative bacterium, so an antibiotic used to fight infection must be able to penetrate and destroy not only this peptidoglycan layer, but also the lipopolysaccharide outer membrane found only in gram-negative organisms. Now, prevention of a Klebsiella pneumoniae hospital-acquired infection begins with medical personnel. Those responsible for the sterilization of surgical tools and instruments must take precautions to make sure that those tools are sterilized and free of pathogens. Once those tools have reached the operating room, it is up to the surgical tech to maintain the sterility of the instruments to prevent infection of Klebsiella pneumoniae.
Today, I will be telling you about Staphylococcus aureus and how it is a major part in surgical site infection. Staph has a common reservoir on our skin and in our nasal passages. Staph grows aerobically on the skin surface and anaerobically in the pores of the skin. Its morphology includes cocci-shaped, it is a gram-positive organism, and it is facultative anaerobic, as I just stated. Its virulence factors include protein capsules, which protects against phagocytosis, invasions, which facilitate the spread of bacteria, the secretion of toxins, which lyse the human cell walls, and an acquired antibiotic and antimicrobial resistance. Staph is also able to withstand extreme environments, high temperatures, and it is halophilic. Some common infections that are associated with Staph aureus include boils, which are a pus pocket that develops in a hair follicle or oil gland, which is commonly found underneath the arms, in your groin, or your buttocks. Impetigo is another common staph infection. It is a highly contagious rash, which usually includes oozing blisters that crust over, as you can see in the picture, with this yellow honey-looking crust. Cellulitis is another common infection, and it is a deep skin infection that occurs in the deep layers of your skin. It's not on the top of your skin. It has swelling and redness, and discharge may occur. But the most important of these that always seems to be an occurring problem in hospitals and surgical sites is MRSA. MRSA most often causes skin infections like sores or boils, but can also cause wounds, can infect surgical site wounds, and can cause bloodstream infections as well as lung infections and urinary tract infections. As you can see in this picture right here, this is how a MRSA infection has started, and it looks pretty gruesome. Some skin infections related to MRSA. 5 to 10% of patients experience an internal infection from a gastric bypass, but it is not considered a high-risk surgery and normally has no complications, if any, at all. According to the CDC, severe life-threatening MRSA infections occur in healthcare settings. 20% of surgical site infections are from staph. 14% of surgical site infections are from coagulase-negative staph. The normal route of transmission is through contact with an infected wound during an operation through suture materials or instruments, which is commonly known as communicable transmission. An individual is susceptible to MRSA, but those at high risk include individuals that are immunocompromised and those who are receiving inpatient health care. It also loves invasive devices such as catheters. Preoperative screening is now being used in culture or molecular-based methods and subsequent decolonization of patients who are positive for methicillin susceptible and methicillin resistant staph. This reduces the chance of a surgical site infection, so that when you go into surgery, they know if you have it or if you don't, whether you're susceptible to it or not. And so now this leads us to antibiotic treatment. Vancomycin is the most common antibiotic prescribed since MRSA is resistant to most traditional medications used. And vancomycin kills MRSA by inhibiting the proper cell wall synthesis, which stops the bacteria from growing and dividing. It also prevents the bacteria from creating its peptogliding exterior, and vancomycin has been the most successful antibiotic to take care of a MRSA infection.
All right, that brings us to Helicobacter pylori. You can see is a gram-negative, curved, bacillus-shaped organism. The curved bacillus is what gives it its name helico, from helix. It resides principally in the human stomach and can survive that acid-rich environment due to many of its factors. Most likely, it causes peptic ulcers, which are stomach ulcers, sores in your stomach, chronic gastritis, and stomach cancer from prolonged infections. Some of its virulence factors. We've got the flagella here that provide motility, as well as enabling it to colonize under the mucosa. Urease enables it to survive the acid-rich environment of the stomach by neutralizing stomach acid. Its lipopolysaccharides adhere to host cells as well as other outer proteins aid in adherence. It has a pill-like structure for secreting its effectors, which are the main cause of cancer for stomach cancer, which causes uncontrollable host cell growth and apoptosis inhibition. It also has exotoxins and secretory enzymes which will cause gastric mucosal injury. Yet again, the ulcers. It's not a common hospital-acquired infection, but it is one that they must take precautions against, such as proper reprocessing of endoscopes and other equipment that would go down into your stomach. If the surgical technologist doesn't do their job properly, they may use a contaminated instrument on someone else and pass that infection on. Normally, it's transmitted from oral to oral or fecal to oral. Now, that's not like you drink something that someone else drinks or you kiss someone. That's more along the lines of like 28 days later, they throw up in your face because it comes out of your stomach. So lower socioeconomic groups and people that are in prison are more susceptible to this because they're in close proximity, they're poor, they don't get good medical coverage. It's a very hardy organism as it does survive that acid-rich environment in the stomach. Now, to treat it, they normally use amoxicillin along with tetracycline. Also, you would need an antacid to neutralize your own stomach acid from further injuring yourself. The amoxicillin is going to stop the bacteria from forming its cell walls, thus killing them. And the tetracycline is going to bind to specific ribosomes and inhibit protein synthesis and stop the proteins from multiplying. It usually takes between 10 days and 2 weeks to fully treat and get rid of an H. pylori infection. It can take a bit longer depending on how large it is, and if it's too large and already caused cancer, you're going to need surgical intervention. Now, back in 2016, they actually found a 5,300-year-old Iceman who had an H. pylori genome still in his stomach. I'll go back over what we covered, the basic anatomy of the gastrointestinal system, its organs, functions, basics. Then we went over the procedures of a gastrectomy, gastric bypass, and a colostomy. Then we looked at the roles and attire and responsibilities of surgical technologists, as well as a few disease-causing organisms, Klebsiella pneumoniae, Staphylococcus aureus, and Helicobacter pylori. Doesn't go away.